I'm Adi Iyer, and this is a PNI Minute. Moyamoya disease is a disease of younger patients, children and young adults, in which the arteries of the brain become progressively narrowed and fragile. And this can lead to stroke-like symptoms, as well as hemorrhage as well in the brain. This can present as strokes in younger patients. So young patients shouldn't be having stroke-like symptoms, which would be weakness on one side of the body, numbness or tingling, facial drooping, problems with speech or language. And if that were to happen in a young patient, they should get a full workup. When younger patients have stroke, the first thing they should get is an MRI scan of the brain. This may show how many strokes they've had throughout their lives, as well if there's a problem within the blood vessels themselves. If so, the next step would be to get what's called a diagnostic cerebral angiogram, which you look at both the arteries of the brain and the arteries of the scalp and the skull as well. And we can tell if there is narrowing in any of those vessels. So there's a higher incidence in Asian populations. In Japan and China, the range is from 1 in 100,000 to 1 in 300,000, whereas in the US, it's about 1 in a million Americans. There's certain genes associated with the development of moyamoya, as well as underlying conditions such as sickle cell disease, for example, which may predispose. It's what happens in moyamoya disease is the vessels become progressively narrow and fragile, and the brain starts to develop numerous small connections to provide oxygenated blood to the brain. And the way we treat that is by doing bypass surgery. What we do is we make a small incision behind the hairline and harvest an artery from the scalp, and we'll tunnel that under the bone and either connect it directly to an artery on the brain, which is called a direct bypass, or connect it to the surface of the brain, which is called an indirect bypass. With an indirect bypass, when there's contact on the brain with the scalp artery, as well as some of the other tissue in the dura, little arteries start to sprout over time, which can also provide blood flow to the brain. Whenever I perform a direct bypass, the patients will also get an indirect bypass. Indirect bypasses tend to be better for patients who are more stable. There's slightly lower risks associated with the indirect bypass. So for stable patients that may have some time for these new blood vessels to sprout, that may be the better option. So when we do a direct bypass, we do intraoperative angiography through the microscopes, and we do flow studies, so we can immediately detect the increased amount of blood flow in the brain, which is immediate. And with indirect bypasses, it can oftentimes take months to see those changes. So after bypassing a patient, we'll do follow-up angiography regularly, every year or so, and you can see the progression of new blood vessels to the brain. Younger patients, I tend to prefer direct bypasses on to give them immediate blood flow. If patients are actively having strokes and they're not stable, I believe a direct bypass is the better option for them to revascularize them as quickly as possible. Recovery time tends to be 2 nights in the hospital, usually 1 night in the ICU, 1 night on the regular ward. I'll put patients on a baby aspirin, oftentimes for the rest of their lives. It's very common to temporarily have some neurological deficits after surgery as the brain gets adjusted to new blood flow. Oftentimes that can be a short period of word finding difficulties, numbness or tingling. It's all to be expected in the immediate postoperative period. Once patients are successfully bypassed, we'll regularly follow them, but we expect them to continue to live a long and productive life.